Hello, welcome to the first of 8 short lectures about ultrasound guided regional anaesthesia. Now, I'll get my caveat out of the way. Ultrasound guided regional anaesthesia is just another way of getting local anaesthetic close to a nerve. And this whole lecture series assumes that you are competent in resuscitation, you know where your equipment is, you've got a trained assistant, you've taken established full monitoring, and you've taken all the usual precautions that you would do when doing any sort of regional anaesthesia. So this just represents another way of doing it. Recently, the American Society of Regional Anaesthesia and the European Society of Regional Anaesthesia issued a joint or a consensus statement about what's required in order to educate you in ultrasound guided regional anaesthesia. Now, if you point your QR scanner to the pattern in the top left-hand corner, that will take you to the PubMed reference, which you can then access through your Athens online account. So this document essentially gives us a syllabus which this lecture series is based on for learning about ultrasound guided regional anaesthesia. So this is essentially Chester's version, which will be up in the training room, and this is what we need to do to be able to what we need to know and what we need to be able to do in order to safely and precisely perform ultrasound guided regional anaesthesia. Fundamentally, it comes down to 3 things. All you need to do is you need to know how to operate your machine and get as good an image as possible. You need to coordinate your ultrasound beam and your needle such that at all times you've got a clear view of the tip of the needle. And then you need to know the anatomy and the sonoanatomy of the area of interest. Now, interestingly, you can practice all of these things without going near a patient with a needle. You can be quite good at all of this before you even start to practice these blocks on patients. So what this lecture series hopes to achieve, along with the practice on Wednesday lunchtimes, is to get you good at all the skills so you can then begin to learn to do it on real patients. This certainly isn't a complete course in how to do regional anaesthesia, and watching these videos will not in itself teach you anything. It'll allow you to approach your learning on patients in a much more informed and coordinated fashion. So the characteristics, some physics first. The characteristics of ultrasound beams. Sound waves obviously are a compression wave which travels through the tissue. They can, however, be described in terms of a sinusoidal wave with a frequency, a wavelength, and a velocity. Now, we can adjust the frequency using the ultrasound machine. The velocity varies depending on the tissue it's travelling through, and so the wavelength will vary with both of those 2 other factors. Now, how are ultrasounds generated? Now, in this diagram, the yellow box represents a crystal. Now, it all relies on the piezoelectric effect. That's to say, if you apply a current across a crystal, that crystal will deform. So if you apply a high frequency current, switching it on and off across a crystal, that crystal will vibrate at a high frequency, and so it'll generate ultrasonic waves. And conversely, if you deform a crystal, a current will be generated. So if you repeatedly deform a crystal, a variable current will be generated. Now that can get picked up and interpreted by the ultrasound machine and turned into the images that we're familiar with. Now, this means that it's the same structures which are both the transmitter and the receiver. It's this piezoelectric array which is switched on and off, or vibrated and then stopped or listened to, which kind of creates the image. Now, you can see that that potentially might cause problems if it's vibrating all the time. So what happens is that these ultrasound waves are sent out in pulses. So the ultrasound probe has two frequencies. One is the actual frequency of the waves, the frequency that the tissue is being vibrated, and there's also the pulse repetition frequency. So what happens is there is a pulse which generates sound waves, and then there's a pause which is when the receiver is listening. So each pulse is usually about three wavelengths, or 3 cycles rather. So the pulse is generated, then it's listened. Now that period of listening, or the time taken for the signals to return, obviously varies with the depth, the depth of the target structure. So the probe, as you change the depth, will alter its pulse frequency. Not very much physics, but it's in the syllabus, so here we are. The returning energy is less than that transmitted, so there is some attenuation. Now that attenuation is due to primarily absorption, so the sound energy hits the tissues, and those tissues are very slightly heated. Now that is it's a very tiny effect, and it's only clinically relevant when you're repeatedly ultrasounding in neonates' heads looking for bleed. So it can cause a significant heating effect in that circumstance, but for us, we can take that effect as being negligible. So another way that energy is lost is reflection, and that's reflection not back towards the detector. And similar to reflection, there's scattering at interfaces. So fundamentally, there's less energy returning back to the probe than left it. So in order to compensate for that, we amplify the signal, and that amplification is the gain. So the gain knob, which we'll go through in a subsequent lecture, amplifies the returning signal. So it makes the screen whiter. It makes every signal received a bit more powerful. So as I said, 80% of attenuation is caused by absorption, and so heat production in the tissue. The degree of attenuation varies with the frequency of the ultrasound. So very high frequency signals are attenuated much more, and so have less penetration. And conversely, very low frequency signals are attenuated less, so they have a much greater penetration. Now, it's a little bit like bats and whales. So a bat will have a very high frequency signal. It has a very high resolution, allowing it to catch flying insects at night, but it doesn't penetrate particularly far, whereas whales have a very low frequency signal. There isn't a great deal of resolution. You can't tell where your whale is, but they can communicate across oceans. So high frequency, high resolution, low penetration; low frequency, high penetration, low resolution. Right, so reflection. What causes reflection? So the acoustic impedance of a tissue is essentially the resistance to transmission of sound waves. Now, it's the difference in acoustic impedance of structures and tissues which causes the reflection. So when there's a very high difference in acoustic impedance, an ultrasound reflection is generated. So air has a very low impedance compared to body tissue, and so wherever there's a bubble of air, you get a reflection. And that's why it's very important to completely clear any bubbles of ultrasound of air from your local anaesthetic solution, because it will act as a barrier to the ultrasound wave, so you won't be able to see beyond that bubble. And similarly, bone has a very high impedance compared to most of the other tissues. So again, there's a very sharp reflection from bone, and there's a shadow behind it. So that's one of the characteristics of bony tissue, which again we'll go through in another lecture. You can't see through it. The other thing that affects the amount of reflection back to the probe is the angle of incidence. And you can see from this diagram that the ultrasound beam on the right-hand side, you're going to get almost all of the ultrasound beam that hits that needle reflected back to the receiver, back to the probe. But the diagram on the left-hand side, much of the ultrasound beam is going to hit the needle, but it's going to be reflected out of the field of receiving of that ultrasound beam. And that's why, if you have a very steep angle on your needle, you're going to get a very poor view of the needle. So always, whenever you're trying to visualize the needle as much as possible, you need to aim to get it as parallel to the probe as is feasible. So a little bit about physics of resolution. Now recently there was an article published in the Royal College CPD journal just about this topic, so I'll put the link on the screen just there. And resolution is fundamentally the ability to see two objects as separate. Now there's two dimensions to that. You can either see them as separate, one deeper than the other, so axial resolution, and that's determined by pulse length and beam frequency. And there's lateral resolution, which is the determination of two objects of a similar depth next to each other as separate, which again is dependent on the beam frequency, and that's also to do with beam width, which is explained more fully in this article. So fundamentally, what we need to know, the higher the frequency, the higher the resolution, so the better you're likely to see superficial structures. And finally, for this lecture, colour Doppler. You'll remember that the Doppler effect, or the Doppler shift, relates to a sound wave bouncing off an object, having its frequency change slightly depending on whether that object is moving towards or away from the receiver. So this is why traffic, when coming towards you, appears to have an increasing pitch, and traffic driving away from you appears to have a decreasing pitch. So on our machines, and most ultrasound machines, if the moving object, in this case red blood cells, is moving towards the detector, as in the bottom picture, it shows up as red. And if the blood or the moving object is moving away from the detector, it shows up as blue. Now, in the top image, you can see that there is no colour signal. Now, that's either because there's no flow in that vessel, which is one possibility, or it means that the probe is exactly 90 degrees to the flow of the blood of the object. So that signal is neither moving towards nor away from the receiver, from the probe, so you don't get a Doppler signal. So it's very important, if you're looking for a Doppler signal, to angle the probe slightly to and from the direction of flow of blood. So in summary, safety first. Ultrasound guided regional anaesthesia is only ever going to be safer if you take all the same precautions you would do for any other regional technique, and you can see the tip of the needle throughout its time in the body. So you need to aim to see the needle at all times. The higher the frequency, the higher the resolution, and the best view of the needle is achieved when it's perfectly parallel to the probe.